So, hello, I'd like to introduce Dr. Tyler. Dr. Tyler gained an undergraduate degree in nursing and pre-medicine, then became a Doctor of Osteopathic Medicine, and later received an MS in Medical Education Leadership. Today, Dr. Tyler is a board-certified internal medicine physician who has practiced in multiple aspects of internal medicine. His clinical practice has encompassed hospital medicine and outpatient medicine with emphasis on chronic disease management, palliative medicine, and post-acute long-term care practices. After the move to academic medicine, he has been able to engage in research and scholarly activities. His current research is structured for reflective learning in combination with observed structural clinical examination in assessing competency outcomes. Now, if all of you could please mute your mics and use the raise hand feature when necessary, that would be very much appreciated. Thank you, and take it away, Dr. Tyler.
Thank you so much. You did great, Haley. It was absolutely marvelous. I'm going to do this presentation not as an expert in research, but as somebody who wants to get into research, because I value the impact of research and scholarly activities on my learning, the learning of the medical students that we serve, and also the faculty around us. I find this to be a really tremendous way to collaborate and to understand a lot of what my colleagues are going through and a lot of what my colleagues do in order to impact myself clinically. I call this clinical medicine research at KCU. I mean, this is really going to be just some examples of, from my standpoint, I'm more medical education based, but certainly carry a clinical purview with that. There's going to be three cases that three ideas that I would like to talk about that I'm aware of, that I'm hopefully going to have some exposure and involvement with. The first of which is a observed structured clinical examination process whereby we combine reflective learning to see if there's a better way to assess competency in the performance of skills clinically. The other one is somewhat of a simulation-based education process that the simulation department is looking at, that I found really interesting and wanted to put out there because it's an idea that's moving. I think there is background work being done on this, and the thought processes in regard to that study, I'm just going to outline just to help define some of the things that we're looking at on the medical education side. And then we have an idea that's in its infancy as we move into a metabolic stress study that I'll explain here in a little bit. So this first one is somewhat of my baby. In my master's program, this was my applied project. And so I worked quite a bit of time on this, and through various iterations, it's still not quite to fruition. Right now, I call it, well, I won't tell you what I call it, but this COVID-19 thing is obviously hindering us being able to proceed. But this study really takes an observed structured clinical examination, or an Oskie, and this is a performance assessment in clinical skills, typically with medical students, that have been used for quite some time. It's expanded from nursing to physician assistants to veterinarians to most probably dental students. I'm not sure, but I do know that even physical therapists and all that will use it as well. This is typically made up of stations that have certain topics. Say, for instance, we're just going to do a cardiac examination, much like this study is going to focus on. There may be three stations, and one is physical findings, and then the next one is what diagnosis would you associate with those physical findings, and then the third would be interpretation of diagnostic in association with that patient presentation. And then there's a directly observed component by clinical faculty that as the student performs each station, they subsequently receive an evaluation and feedback. And then we have the ability for the student to look at their level of learning and what they performed on the Oskie examination, and they can approach learning gaps or processes by which to improve. Well, the addition of reflective learning is in there to say, is there a better way or an additional way to augment how we look at competency? What is that in regard to medical education, or what is it in regard to learning? We know that in medicine, we have different curriculums. We have things that we call milestones, where you hit this developmental piece, and then you don't really progress to the next milestone until you have mastered that first milestone. We do have core competencies as laid out by the Osteopathic Association, or not necessarily the Osteopathic Association, but by the osteopathic community. And then we have the allopathic community, where we have entrustable professional activities that says this is what we feel as though physicians should demonstrate as far as competencies moving forward. Well, when we look at reflection, this is really processes whereby students just think about what they're doing or relate this lesson to real world experiences, and they work to make meaning out of the material. And then we look at learning specifically in that we obtain some sort of content through a particular type of delivery. And the processes in medical education particularly are that we're able to take a look at that topic of information from different perspectives. And we want the student to look at all those perspectives and actually transfer information from those observances into something that they can develop, construct, ask questions about, explore, dissect, whatever you want to call it, and develop more deeper understandings or effective learning, essentially. With this Oskie thing, can reflection do that? In processing performance, in qualifying it, in quantifying it, how do we actually get to the point where we can assume that reflective learning, being able to rehash it even more defined, looking at it even deeper, allowing the student to get guided into a deeper prospect of the topic that they're going to be looking at, will it actually increase their competency? So the idea is you look at a new experience based upon the learning that you have bringing with you. You think about that learning and you relate it to an idea, and hopefully you're able to move deeper, advance in your learning in order to have a different thought process or a different experience that makes that knowledge better for you. So that's what we're looking at: a control group who goes through a regular Oskie process, and then a study group who actually has the reflective exercises added on. There's not really a significant amount of data that is related to the Oskie for sure, but we do have a lot of data that questions the Oskie in that it looks at one point in time. It has a lot of validity and reliability that's in it because we have different faculty observers and different rates and methods of rating these performances. So if we combine that with a reflective activity, we provide self-evaluation and some sort of other assessment process in regard to an experience, will it make it more meaningful? Well, that was the first one. The second one is something that is really more simulation-based, and I know that there is a lot of activity happening on this, and obviously with COVID, everything is somewhat slowed down, but I wanted to show you how this study can impact clinical medical education as well. And I call this the PITA study. I'm not sure that that's formal at this point, but PITA stands for Physician Examination Teaching Assistant. As we look at what a PITA is in medical education, you may very well know that we use standardized patients to be trained to assist in giving medical students opportunities to use their clinical examination skills, look at interviewing, look at history taking, practice things like patient safety and comfort, looking at professionalism, metrics, and humanism qualities. And the standardized patient actually gives a lot to the medical students development in their clinical skills assessment. And this process is a simulation environment. The PITA actually takes this further in that this is an even more specially trained standardized patient who can provide the instruction based upon those physical exam techniques, and they can help the medical student learn issues of patient safety and communication, and talk to them about methods of professionalism and humanism from a basic standpoint. These are all important to their education, but this considers the ability to provide this instruction not in place of a clinical faculty, but in association with a clinical faculty where there is oversight. But this allows possibly more freedom of that clinical faculty in delivering more advanced processes in regard to the student's education. So I kind of outlined this already, that the PITA, the presumed benefits are that there's a focused instruction, there's some clinical time that can actually be somewhat regained for the clinical faculty because they've got somebody who has been specially trained to help them in some of the basic instruction delivery. But we do have to look at particular standards, provide the oversight, and consider issues such as funding, because these specially trained folks are not going to be exactly cheap, but it may actually be an offset and have a return on investment that could very well be considerable. So the thought process, at least from a global standpoint, is that the validated training for these teaching assistants, and we propose a pilot study to look if there might be a performance difference in those that are trained with the PITA augmentation versus those without. So that would be one idea of the basics of this study. And this really is at a point where, to us, it feels like a great idea. It seems extremely feasible to look at this, moving through the processes of figuring out how to structure this specifically. Hopefully are going to come through a further collaboration with the simulation experts that we have at KCU. So that's the PITA study. Another thought that is essentially in its infancy is to look at medical student stress, because we're very focused on wellness, self-care, and the ability for students to find balance. And this is particularly important because I've been doing this for a long time, and this was always something that was internally motivated. No one really helped you. It seemed as though no one really cared if you were stressed out or not. You just needed to get through medical school and get it done. But now there is a lot more to medical student stress because we see that there are cultural and societal issues that are quite significant. And so a lot of medical education has taken the onus to be accountable and take ownership of a lot of things in order to help medical students navigate through their training. Because medical student suicide is a concern. Obviously, the lack of wellness, the lack of being able to continue self-care certainly doesn't help them at all in their process through medical school. So we want to try to optimize that based upon the literature we have. Well, the thought is, can we actually look at the differences in medical student stress from a metabolic standpoint by looking at something as simple as salivary cortisol? So we know that stress looks at physical, emotional, mental, particularly. So if we have the ability to have, say, two groups, one that either has like a nominal to mild level of exercise just to maintain their wellness and self-care as much as possible, with the same amount of academic or didactic stress in medical school. We've got another group who may actually have a higher level of exercise. Can we utilize the salivary cortisol to express those positive effects or those benefits that we typically presume and a lot of times can see to some degree in the literature? Well, that would be looking at, would decreased overall levels of cortisol plus in this study, plus exercise, would that indicate less metabolic stress? Or would those students that are undergoing these studies, plus having an augmented level of exercise, have cortisol levels that didn't make any difference? We're wanting to start looking at the literature a little deeper to see how to form our research question more appropriately. But those certainly are our original tenets in looking at this study. And this, of course, we can easily do here in Joplin, possibly add to the Kansas City campus, but would certainly be something that we could run from the MKRC.
Dr. Tyler?
Sir.
It's okay, I hope, to interrupt, but Dr. Creamer has his hand up. Are any questions at this point?
You know what? Let's do it, because I actually don't need to share anything more, and questions would be perfect.
Oh, Dr. Creamer.
All right, that was awesome. Thank you for sharing that with us. My comment / question has to do with your last study on exercise and stress. That's a study after my own heart. And comments that I would first make, I love the idea of measuring cortisol. It's something that I've looked at in my own studies. It's kind of tricky, as you probably are aware. There's all sorts of fluctuations that have to be dealt with, and the idea of collecting over certain periods of time. I've started investigating other markers of stress, and there's a lot out there that are starting to have validity, that are somewhat easier to measure, less fluctuation. So inflammatory cytokines are heavily linked with stress, and specifically IL-6, TNF alpha, and a few more that I've been looking at in a study that I'm working on in first responders, and they've been getting osteopathic manipulation, and we're looking to see over time if we can decrease their markers of stress, these metabolic markers. So anytime you want to chat about those, let me know. I've got some journal articles I can send you as well.
I'd like to interface on that and just add to it and say that the lab in Joplin at MSSU that we call the BMRL, Biomedical Research Lab, is in the process, or was pre-COVID, of getting qualified to handle human blood. So that's something this community needs to know moving forward. Jared Nichols.
Yeah, so I was just going to say that, if you have blood baselines on those people prior to COVID, it might be interesting to do, especially if they're still acting, they're still in the field, to see what they are now after COVID. That might be a whole different research thing, like, the effects of COVID. If you already have your baseline, but I see that you say that they're high, but are they higher? I don't know. That might be interesting. Yeah,
unfortunately, and sorry to hijack this, Dr. Tyler, that's not my intention, but the study didn't include, any sort of 6-month follow-up because it's a pilot. It was just to look at the validity of some of these markers and some of the osteopathic techniques that we were using, and to create an expanded study from this pilot is the ultimate goal. But yeah, it'd be great if I could do that. Unfortunately, I think it would take a lot of finagling of IRB and things like that really quickly, as well as getting all sorts of permissions from the university to have either myself or whoever would be my qualified phlebotomist to interact with folks from the community in such an intimate way for this project. So at this point, I don't know I think that's a great idea. What has the COVID done to first responders or really anyone's stress level? But
if you could get a grant, they could just go to Quest or any other lab and get their blood drawn and then sent to you.
Yeah, that would be nice.
Okay, I see Dennis Wolf has his hand raised. Dennis.
Yeah, I was going to second Jared's comment there. That struck me as being a really, really good idea. One of the things, though, with the stress that's always been of interest to me is that with chronic stress, some of these things go down. So many times in people with PTSD or whatever, their cortisol levels are lower than normal. And so it's also within the realm of possibility that you could go out there and see people now in the COVID environment where the cortisol levels would be low, and to some extent that also years ago I always the idea of the psycho-immunological interface or whatever, kind of the idea of the survival of the fittest type thing, so that if you're able to cope, then your cortisol and then everything is up there. But if your mind, so I used to joke, 20 years ago that people didn't get better if they thought they were going to die or whatever. I mean, if you had to have the right mentality for all of that stuff, and if you were unable to cope with your environment, you kind of willed yourself into the grave, and that was kind of contributed then to the survival of the fittest. And so so this is armchair speculation without data, but it's one of the things that always struck me as being rather interesting.
Well, I will take a moment to comment that these are all really interesting aspects to hear, because this particular idea in regard to a research project is in its infancy. And so really trying to define all the variables that could be anticipated and then looking at the literature to see what has been said about this before. It's somewhat like I'm not a DIY guy, but I go in to fix my hot water heater and get into it and realize why did I even start this? So that oftentimes happens in research, and so that may be where I end up, because some of the stuff that I've looked at already does talk about multiple mediators in evaluating metabolic stress. It also talks about a lot of waxing and waning data that doesn't really follow some sort of a reproduction in other studies. It tends to lack or exceeds or whatever. So there would have to be a lot of considerations in this study for sure.
Don't fear. We're here to help you.
I just put that in the chat. You're now a member, fully functioning member of MKRC, Dr. Tyler. So we're here to work with you on this.
You have our support and love.
Give our support, yeah.
I think it would be an exciting project to get in on from a medical student standpoint, to see how this thing builds. And so I think that's the appreciation in this, is that we can all learn together, and medical students can get involved and actually gain some pretty valuable concepts moving along.
Absolutely. Oh,
Devin's got his hand raised for a long time.
Say that's been my favorite part of the study I worked on, was involving the fellows. The OMT fellows were the ones in my study that actually were delivering the treatment, if you will.
Yeah.
So that was, the students were all over it.
Student Dr. Volker, it's nice to see you again. Your hand is raised? Or maybe he left the room. Dr. Volker, student Dr. Volker, are you there? Okay. Dr. Wolf, I see your hand is raised.
Okay, and you unmuted me, so thank you. And of course now I forgot my comment, but no, actually what I was thinking was that, the whole idea of coping, to what extent people can can cope with isolation. And so, I mean, we've made the comment that, you know, I'm sitting here at home. I got my toys. I don't need to talk to people. I'm happy for long periods of time. I'm a solitary introvert type of person until I get in an environment like this and can't shut up, I guess. But for the most part, I'm fine by myself. Whereas other people sit there and they really, really need that human interaction. And so I was going to suggest that if you were going to do something like that, there's a guy by the name of John Pelly or something like that from San Antonio, Texas, a medical educator, looked at the personality profiles of people and what kinds of hospital fields they ended up in, which personalities are drawn to certain things. But he was a person that said during his session said two things that I've always remembered, and so I've shared it with some of you. Is, you know, when do you feel your smartest, most accomplished? When you're overcoming obstacles to do something new for the first time and succeeding for the first time, or when you are flawlessly performing something that you've already mastered. And I was so far in the former category that it never even crossed my mind that the second category would exist. But nonetheless, we do need people in both of those categories. The other thing that he said, though, was you can tell whether or not you're an introvert or an extrovert based on what you do when you get home after work at the end of the day. And so when you get home at night, do you go, oh, God, and you collapse in the chair and, you know, pick up your guitar and veg out and watch TV or something like that? Because during your daily activities, you were more active than you were accustomed or wanted to be, that your body was geared to being, versus an extrovert where you get home at night and go, oh my God, I got to get out, and you got to run out and do something because you were cooped up all day. You couldn't engage in the manner that you were. And that too struck me as being an interesting dichotomy or whatever. And so for people that are not introverts, I'm thinking that this might be an especially difficult time.
Not sure that was a question, but I see that student Dr. Volker is back in the chat in the room. Student Dr. Volker, can you hear me?
That I can. Can you hear me on your end?
Yes.
Excellent. I had an issue with my web browser earlier. Dr. Tyler, I had a practical question, I guess, about your first point with the kind of practical learning and short stations and all that. Oh, yeah. In my head, I'm just kind of wondering if you could provide a concrete example, because I'm just kind of thinking it's some sort of hybrid between when we do our osteopathic practical exams and TTC from 2 years ago. So
the transition to clerkship 2 years ago, let's don't even use that as an example. What the Oskie particularly will do is, let's say that you've got 5 stations that you need to go through. And as you go through that station, you've got a faculty member or a fellow or a resident or somebody there that's gonna give you instructions. And there may be a standardized patient. There may be a particular simulation-based, like a SAM that we use at KCU. So the first section is head, eyes, ears, nose, throat, and neck. You've got to go through that examination. Second station, you do the cardiopulmonary examination. Third station, abdominal. And you have to move through these 5 stations within a certain amount of time. And then at the end, each faculty member that has graded you in those stations has either filled out a checklist or some sort of an assessment form. You get a certain number of points, and the final faculty sits down with you and says, Devin, this is how you did. And then they basically tell you your grade, and they go over the good points, the bad points, whatever, and you move on. And so a lot of times in the preparation for this, you'll get the checklist and you'll get an outline of these are the parts of the body that we're going to be examining today. You will be examining in this test, and you study on your own accord. It might be that we've got a physical exam session, a diagnosis session, and then a diagnostic imaging interpretation section. It's kind of the same process. Whenever we add on reflective learning, this study specifically puts the reflective learning exercise as a process where we say, all right, let's set your goals for this based upon what you're supposed to know. Let's look at what you expect yourself to do. What do you see as far as learning gaps? If you take a look at these different body systems, is the cardiac one your best? Some people may study for this in that detail on their own just because they're, independent learners and they go through and set goals and expectations, or they really look and ask these questions of strengths, weaknesses, what do I need to learn, what do I want to learn? But we don't necessarily know how to look at things reflectively. And so that's why bringing this into bear actually gives us more information regarding reflective learning and what it can do for us, particularly if we can show that there is a difference in how we measure that performance at the end of those two groups going through the Oskie format. That was long-winded. Does that help you, Devin?
That it does. Thanks.
All right, sure.
Student Dr. Brahman.
Hi, can you hear me?
Hi, Uwais.
Hi, Dr. Tyler. Thank you for your presentation. I had a quick question regarding the PITA section of your study. So do you have of where exactly those physical exam training experts would be implemented in the medical student education process? Would you them replace physicians in our lab sessions, or would they be additional component of our education? Because I feel that I and many classmates find that one of the best things about learning the physical exam is having FaceTime with physicians so that you pick up the nuances of the physical exam. And it'd be great to have people who are educated in that and more FaceTime with that. But then if it's a replacement process or the physical exam training experts are replacing physicians, then you kind of lose that nuanced experience from the actual physicians as well. So do you kind of have an idea where they'd be implemented?
Yeah, so let me just make, I presented the teaching assistant as an idea of some research we're looking at, but the PITA process is real, and usually this is not going to be denoted as something that's going to replace a physician, because a physician would certainly be stupid to do a study, well, not stupid, sorry, wrong word, would be crazy to do a study that's going to prove that they could be replaced, right? So the thing that we would want to look at is this an augmentation that's a reasonable expectation for the medical students? Let's say that the PITA is going to help discuss the otoscope and the stethoscope and the ophthalmoscope, while the clinical faculty are in the second year class, getting them through a much more detailed physical exam process. And then they come back after they've gotten some instruction from the PITAs, and we have a lab environment where the PITAs are kind of going around and say, yeah, this is how you turn on the light, versus the clinical faculty coming through and saying, okay, now that you've turned on the light and you're looking at the ear, this is how you interpret that. So it really is separating out the roles. It's allowing specialization where specialization is needed at the level the specialization is necessary. So in other words, giving basic instruction, basic details, and not interpreting those things, that's where the PITA is going to come in. When it gets into, I hear something crackly and noisy in the lungs, it doesn't go there. But the physician will come in and say, all right, you knew how to listen in the posterior quadrants of the thorax, but now that you're hearing this, let's work through that.
Thank you.
Sure.
Jared, I see you have your hand up. Is that right?
And then I realized that Dr. Kramer had answered my question in the chat because Zoom, Life Size is not like Zoom, so you have to actually join the chat. And I think Dr. Kramer and I may be the only two people in that chat. So it was a PhD question about a proposed study, and I didn't want to take up Dr. Tyler's time. So that was all.
Thank you for that consideration. I'm going to ask a question a little bit off topic, but Dr. Neeson, I think I'm going to attack you. Since you're in the room and we have an opportunity, I have just a couple minutes before I get to go in front of curriculum committee, but I'd like to take this opportunity to ask you to share broadly from a 100,000-foot view what your vision for research infrastructure in the dental school building looks like these days, and your vision for research endeavors and thrust of research.
So I hope you can hear me. There's some drilling outside my window, so that just started. But as I listen to this, it's really interesting because we, in dentistry, we have simulation exercises, we have Oskies. We haven't done the entrustable professional activities yet that I'd like to see us start. But we haven't done that. Because our dental students have to graduate as beginning practitioners. They don't have to do a residency. They will graduate and the next day go into practice. We have to educate general practitioners. We have to educate dentists to become general dentists the day after graduation. So dental clinic, we're going to have a dental clinic where the students are going to provide patient care on a daily basis as part of their learning to be a general dentist. But all of the things that go on in medicine, I'm listening to this study thinking, first of all, I got to tell you, I love any kind of research that uses salivary measurements, because saliva, so I have a bias. I believe saliva is the Rodney Dangerfield of bodily fluids. It's the bodily fluid that gets no respect. You can measure almost everything in saliva, and barely do we do it. And as dentists, I believe we should be doing an oral exam, taking saliva, measuring it for pH, measuring it for various organisms, measuring it for all sorts of stuff that we don't do now as part of the standard of practice. So I want to see our students. My vision for our students is that they're integrated into Kansas City University. They're comfortable with the medical students. They see simulated patients together. Dr. Tyler, when you say, gee, they're doing the head and neck exam, I want the dental students there and maybe teaching the physicians how they look in the mouth, and then having the medical students teach the dental students how to listen to a heart, and listen to lungs, because they take blood pressures. We could be doing hemoglobin A1C in the dental office, with a finger stick. So now as they're developing antibody tests for COVID, we could be doing antibody tests, using saliva. So for research, this is going to be a really long answer, and it's probably a really unfocused answer. But I see the research aspects working in a number of areas. On our strength, we build on what does the university have in terms of basic science research, and are there opportunities to build on that? We're in an community. Are there public health science type research projects that we can do with the medical students, the dental students, other health profession students in the area? And then sometimes, usually what happens in a dental school is there's usually basic dental materials research. That if you get some engineers together with some dentists, they'll think about how they can make, composite material better, or, make different stuff. We're touchy-feely, we're an arts and crafts. We make a lot of stuff. We make sculptures in people's mouths. So the research usually is basic biomedical sciences, the applied clinical dental materials, and then the public health approach to research. But I'm really excited because I think there's a lot of opportunities for building on collaborative research programs with our NIDCR, our National Institute of Dental and Craniofacial Research, with HRSA, looking at with the Health Resources and Services Administration, looking at education projects. I know resilience and grit and are issues for both medical dental students, health profession students in general, and faculty and residents too. So, research we do on that area, I think, is really critically important. So I think there's lots of opportunities where we can get together. We developed a basic science curriculum that's a little different, that it's not, we do have the anatomy, but it's not biochemistry and physiology and pathophysiology and immunology or genetics. It's the basic science curriculum around 60 cases that people get. So it's a systems approach. So we'll start with cardiovascular system, and then the first case is a myocardial infarct. So what do you need to know about the anatomy of the heart, the physiology of the heart, the pathophysiology that a myocardial infarct, what's the pharmacology, any immunology, that sort of thing, so that the students learn the basic sciences in the context of a patient, which I think is terrific, because I think it helps them tie the basic science information to the patient. So any opportunities where we can build on what medical students are learning, I'd love to have us do clinical, pathologic conferences, CPCs, with a patient if possible, with medical students and the bioscience faculty, where you've got, the science behind, this disease. So I think there's all sorts of creative educational and research things we can do. So I applaud your research, Dr. Tyler. It's really very interesting.
Thank you for that answer. Yeah, thank you. I just wanted to add then that one thing that excites me about my career at KCU is getting to watch the dental school endeavor unfold in front of my eyes. I had the experience of watching the medical school open, but the dental school, I think, brings a whole new dynamic, and my excitement level, my cortisol goes through the roof when I think about opportunities to do saliva and oral microbiome. So I would just implore you to get with the architects and put a wet lab in that dental school. That's just an ask. Sorry if I'm out of line.
That's interesting, because right now, I don't believe there's lab space in there. That's a very interesting insight. So, but we do have space. There is a shell space on the 3rd floor next to the sim lab. And, so that's an interesting insight.
Something to think about.
Need to because the truth is, we're rethinking office space. We just learned the last 2 months that everybody can work from home. You don't necessarily need an office, but you do need people in, and you need places to collaborate. So that's interesting. Yeah, we do.
The dental clinic.
I will bring that up. Thank you, Jeff. That's a good insight. Thanks.
Jared.
While I have Dr. Neeson's ear, I just wanted to say that part of my education is interprofessional development. In my, if you don't remember, I'm the osteopathic skills course director for year 2. And I'd love to interview you about dentists and all that stuff. We teach students about SLPs, OTs, PTs, chiropractic, neurosurgery, anybody that you might refer to. And we're still expanding that part of our curriculum. And usually they're just like 5-minute videos